Diagnosis of gastrointestinal problems. Now, we're not going to cover the normal chapter. You can do that on your own. That's chapter 32, pages 821 to 831. Assessment. History you'll find in a box on page 833. There's also a box on 834 that talks about the contents of what's in each quadrant of the abdomen, and you should know that. Particularly if you ever plan on working in the emergency room or critical care. Inspection of, actually med-surg too, anywhere. Inspection of the mouth. You're going to look at the teeth, the gums. Is there any odor? Do they have any dentures and any dental cavities? You're going to look at the abdomen. Again, color. Are they jaundiced? Are there any scars, lesions, or petechiae? What's the contour? Is it concave or convex? Are there any peristaltic waves that you can see? That usually only occurs if you have somebody who's very, very thin. Are there any striae? Now, the old ones will be silver colored. If they're pink to purpley colored, they're probably Cushing syndrome. Cullen's sign is a faint hemorrhagic patches around the umbilicus that are blue colored. They occur 1 to 2 days after anorexia, acute pancreatitis, a massive upper GI bleed, or a ruptured ectopic pregnancy. Gray-Turner sign, on the other hand, is when the flank is kind of bluish colored, and that's also due to an intraperitoneal bleed, both of Cullen and Gray-Turner sign. You want to look for, as I said, the contour. Is it flat, concave, round, distended, asymmetrical, like there's a mass in it or enlarged organs? Do they have ascites or are the flanks bulging? Peristalsis, as I said, you should only see if the person is very, very thin or if there's obstruction present. You're looking for pulsation. It could be an abdominal aortic aneurysm. But again, this could be normal in the epigastric area. So if that pulsation is there, you need to figure out a little bit more about it. You need to auscultate. Now, the next thing for the abdomen is you auscultate before you palpate. That's what's different here than anywhere else. My clock was just playing a Christmas tune, and so I just decided to pause the presentation for just a second. Now, vowel sounds. Normally they're very high-pitched. They gurgle about every 5 to 15 seconds. Your colonic sounds are low-pitched and more rumbling. And for abnormal sounds that you might find, they're on a table on page 835. Keep in mind that you have to listen for 5 minutes in each quadrant of the abdomen before you can say there are no vowel sounds. That means a total of 20 minutes with the stethoscope in your ears listening. Physicians will never do it that long. But you as the nurse have to do it that long before you can say that they're absent. If they're absent, it might be that they have an ileus, inflammation, an electrolyte problem, or ischemia. If they're very, very soft and widely separated, there could be a problem. If they're very loud, it could be that they have diarrhea or an early intestinal obstruction. If you hear a bruit, now this you hear best with the bell. And there's a picture on page 835 that tells you the best places to listen to a bruit because you want to listen over the blood vessels that are there. Percussion can relax tense muscles. Percussion is good to identify the size of the liver, the spleen, and the pancreas. It's also good to help detect fluid, gas, or masses. Palpation, you want to do light first, and light is about 1 centimeter deep. And this checks basically the skin and the fascia. Then you want to do deep. Now this is going to go 4 to 5 centimeters deep. This causes rebound tenderness and guarding. If they have it there, it means that they have an inflamed peritoneum. You always do percussion before palpation because it does help to relax those tense muscles. And keep in mind, it's normal to hear tympany over the stomach and dullness over the liver and spleen. If you hear it elsewhere, it may indicate a mass. Dullness over the flanks may indicate ascites. You want to palpate any areas of tenderness last. So if they've had recent surgery, you leave that area to the very last. There is a table on 837 to 8 that talks about the different assessment findings with symptoms, their history, and each individual condition. It's a really nice table. Lab studies, there's a table 838 to 839 that will help you here also. You want to assess their stool, culture and sensitivity of the contents, and the acidity of the stomach contents. With the liver, if you're anticipating problems with the liver, you'll do an alkaline phosphatase. This will increase with hepatic or biliary obstruction. You'll do an SGOT, which is now called an AST in many places, SGPT, which is also called an ALT, or an LDH. These show liver injury. Now, your LDH can be fractionated into 5 different fractions. Fraction 5 will increase with hypoxia and primary liver injury. Fraction 1 and 2 will flip if you've had an acute MI, but the LDH fractions can give you a lot of good data also. A bilirubin can be either indirect, which is looking at your unconjugated bilirubin, or your free bilirubin, and that will increase with hemolysis. Kupffer cell injuries, Kupffer cell injury to the cells in the liver. Your direct bilirubin looks at your conjugated bilirubin, and that will increase with obstruction or liver injury. Your total bilirubin will increase with biliary obstruction. Your urine bilirubin will decrease with obstruction, and your urine urobilinogen will increase with hemolysis or shunting of the portal blood. So they will tell you different things that are wrong with your patient. More liver studies, your protein. Your albumin will be low with liver injury, and your globulin will be increased with hepatitis. Your AG ratio is normally 1.5 to 1. You have more albumin than you do globulin. That will reverse if you have chronic liver disease. Blood clotting factors are also affected because they're produced by the liver. Your ProTime will increase with cirrhosis or vitamin K deficiency, and your APT will increase with severe liver disease. Your pancreatic lab studies, your amylase, your normal 60 to 180, it will increase with inflammation. Your lipase, the normal is 1.5, and that will increase with inflammation. And your urine amylase will also increase with inflammation. Now, steatorrhea is stool fat. It is foul-smelling, frothy, it floats. It occurs if you have malabsorption syndrome or any condition wherein fats are poorly absorbed, such as celiac disease, where they cannot digest gluten, wheat, and oats and stuff. Or if you have decreased lipase, because that will give you an increase in fat in the stool. So if you have somebody who has pancreatitis, these will all be changed. Endoscopy is used to identify lesions, mucosal changes, obstruction, motility dysfunction, or to do a biopsy. An EGD is looking at your upper GI bleed. It is an esophagogastroduodenoscopy. Initials are a whole lot easier. It can be done at the bedside. Colonoscopy is looking for a lower GI bleed from the rectum to the distal ileum. And enteroscopy is looking at your small bowel, and that's beyond the ligament of Trias. And ERCP is looking at your biliary and pancreatic ducts. It stands for endoscopic retrograde cholangiopancreatography. Nursing care for endoscopies, there'll be NPO for 6 to 12 hours. They need the lower GI portion needs a small bowel prep ahead of time. Most of these can be done at the bedside. Some of the risks that go along with these are bleeding, aspiration, perforation, vasovagal stimulation, and oversedation. Signs of perforation that can occur would be abdominal pain, distension, GI bleed, and fever that's unexplained. Angiography can be either diagnostic or therapeutic for treatment for a GI bleed. Angiography is used to evaluate the status of the GI circulation. You It can be also done to achieve transcatheter control of a GI bleed, which is where they would inject at the site of the bleed gel foam or a vasopressor. It can also be used to evaluate cirrhosis, portal hypertension, intestinal ischemia, and other vascular abnormalities. Complications are the same as those for a cardiac cath, but they usually use the femoral artery for access. There's a figure on page 840 that shows a GI bleed, what it looks like on the exam. Plain film of the abdomen, or a flat plate of the abdomen, can see air obstruction or perforation, and there's a table on 842 for the findings that you should be looking at there, and a picture on 841 that shows it. This is the one that's also done to verify tube placement, NG tube placement, or feeding tube placement. An abdominal ultrasound is used to diagnose gallstones, hepatic abscess, hematoma, or candidiasis. It doesn't work as well in the presence of ascites, extreme obesity, or intestinal gas. But there is a figure on 840, as I said, that shows the GI bleed. CT of the abdomen identifies lesions that are greater than 2 centimeters in diameter. So it will show an abdominal abscess or pancreatic pseudocysts, biliary obstruction, or GI neoplasms. A nuclear scan or a hepatobiliary scintigraphy identifies acute or chronic cholecystitis, biliary obstruction, or bile leaks. It's done by injecting a radiotracer dye through an IV site. If pooling of the dye at the liver occurs, it means you have poor uptake and liver dysfunction, as the liver cells take up 80 to 90% of the dye and then secrete it in the bile and out through the biliary system normally. For this, they're NPO for 2 to 4 hours before the scan, and they have to lie flat for an hour. This also helps in identifying organ size. A GI bleeding scan is also a nuclear study. It's only good with when the patient is actively bleeding. But it adds a radiotracer to some of the patient's own blood and then re-injects it, and it goes to the site of the bleed. This can be done at the bedside, but if the patient has stopped bleeding, it's of no value at all. An MRI helps to identify tumors, abscesses, hemorrhage, vascular abnormalities. An MRCP is a magnetic resonance cholangiopancreatography. It will identify problems with the biliary and pancreatic ducts. It uses a non-iodine-based contrast media. This is a very lengthy procedure. It must be done in the department, and they can have no metal, and they are in a very enclosed space, so it doesn't help if they are claustrophobic in any way, shape, or form. Percutaneous liver biopsy identifies cirrhosis, hepatitis, and infection, also cancer. For this, they must be NPO for 6 hours before and have coag studies completed first. Why coag studies? Well, hemorrhage is a major complication. The incidence is very low, less than 1%, but the liver, it does produce clotting factors, and if there's disease of the liver, they may not be producing a sufficient amount. After the test, they must be placed on their right side for 2 hours. Why? Well, hopefully you said that it provides pressure over the surgical site to prevent hemorrhage. Other possible complications might be infection and peritonitis, particularly if by chance they puncture the gallbladder. It may cause a sensation of deep pressure or dull pain radiating to the right shoulder during the procedure. This is usually done in radiology under fluoroscopy or CT scan. It can be done at the bedside, but they need to go to the department for image guidance to make sure they're doing it in the right place. And that finishes this section of GI.